This video is sponsored by the Association of Anaesthetists, A-Line, Health Education Northeast and NEMO.
Our next speaker now, who is Dr. Ayat Bashir. Ayat is an academic clinical fellow in diabetes and endocrinology. She's also a clinical academic equality, diversity, inclusion representative in the Newcastle University Translational and Clinical Research Institute. She's been an advocate for Black History Month in Islam, and she will be speaking to us today about Black Lives Matter movement and COVID-19 putting racism in the spotlight.
Hello, thank you very much. So first of all, thank you very much for the organisers for letting me speak today about a topic that I'm really passionate about, and the importance of Black Lives Matter and in the context of COVID-19 and racism. Surprisingly, people wouldn't put all these topics together, but it's kind of surfaced over the past few months that this is a really important topic. And on a personal note, I've been affected by racism throughout my life since childhood, and it's something that we unfortunately we have to live with. And hearing the talks over the past over the course of the day, some amazing talks, and I've related to a lot of them, and in particular the talks about sort of subtle racism, not sort of direct racism, but subtle racism that we can experience in the workplace. As a newly sort of graduate from medical school, I graduated here in Newcastle, and I was really excited about being a junior doctor. But I was faced with a warning by sort of certain colleagues, and they were saying to me, "I've got to be careful as a Black Muslim, female Muslim. I've got to be careful on the wards. I've got to be extra nice. People are going to be waiting for me to trip up. I have to work extra hard to be able to show my abilities." And that was nerve-wracking, especially starting as an F1 on nights in a new environment. I had that extra pressure, and I still got that extra pressure every time I start a new rotation. It's always in the back of my mind: what are people going to think about me? How are people going to treat me? And it's something that hasn't disappeared, and it won't disappear unless there's solutions to this problem. So that's why today matters, and what I'll be talking about specifically is COVID-19 in the context of Black Lives Matter and how it has actually put racism in the spotlight. So as most people are aware, Black Lives Matter became a global thing in the summer of this year. And Black Lives Matter is a decentralized social and political movement that advocates for non-violent civil disobedience in protest against all racially motivated violence against Black people, in particular police brutality. So when did it all begin? Well, it all began in 2013. Actually, this is not a new thing, and it began after acts of racial abuse and police brutality, and it became a social media hashtag. And the difference this time round was that it all came about in the middle of it all came back in the middle of a global pandemic, and it just showed that actually racism won't stop in a pandemic, and people still went out. And what we did realize from the protests of Black Lives Matter is that it wasn't just about police brutality. It was about every act of racism or discrimination, injustice that was occurring in all aspects of people's lives, whether it was at work or whether it was due to people's socioeconomic status, wealth. There was racism, and it existed, and people went out to protest against this, not just about police brutality, but about racism in general. And it's really important to say that actually pre-COVID-19, racism and health were two areas that coexisted, and experiences of racism have been associated with adverse health outcomes, in particular for the Black and ethnic minority groups, including anxiety, depressive symptoms, a range of cardiovascular consequences, maternal mortality, and very low birth weight. And this actually does contribute to inequalities in the delivery of care. There are barriers to accessing care. There's a lot of, as a result of these problems, there's a loss of trust, and there's also psychosocial stresses. In terms of the NHS isn't, as we've heard today across the course of the today, isn't immune to racism. And racism does exist in the NHS, and as we've heard today in previous talks, there's differential attainment by ethnicity in the medical workforce. Ethnic minority doctors are more likely to face referrals to GMC, more likely to have their cases investigated, and there are, as also been mentioned today, the differences in ethnicity in doctors' pay, likelihood of experiencing bullying and harassment in the workplace. So, we've heard today, and I've just reiterated this all been mentioned. Staff have been subject to more inappropriate behaviour, and for me it's more so what's difficult is that indirect, that subtle racism. So when you walk on the ward, the way that people look at you, the way that people greet you, that can also can have a really detrimental effect on staff. So when it comes to COVID-19, it was striking. From the beginning of February, March, we were faced with these shocking statistics. We were always showing these pictures on the media of people dying from COVID. And what was shocking was that in terms of key health workers, the first 10 doctors were all ethnic minority, Black ethnic minority doctors. And as you can see here, most of these key workers, these are the initial people that died from COVID, were all, most of them were from ethnic minority backgrounds. So this was, a shock to people. It was really worrying. And what was more concerning as well at one point was even Filipino nurses. They counted for 20% of COVID-related deaths amongst healthcare workers. So it was clear that there were COVID-19 inequalities. And in terms of the statistics and the data that was emerging at that time, it was clear that the highest age standardized diagnosis of COVID-19 was among Black ethnic groups, and the lowest were in people of white ethnic groups. And also in a recent prospective cohort study, Black, Asian, and minority ethnic healthcare workers had an increased risk of COVID-19 compared with non-Hispanic white healthcare workers. So it was clear that data was emerging, that there was a difference. And in a really, really large study, a systematic review and meta-analysis published in The Lancet, of 18 million patients from 50 papers, the prevalence of COVID infection was highest in the Black ethnic minority groups, and Asian, also in Hispanic individuals were also most likely to become infected. ITU admission was also higher in these groups of people, and mortality. And when we come to looking at COVID-19 deaths, so this is the Office of National Statistics, which regularly produces data about COVID-19, and you can see that the males of Black ethnic groups aged between 9 and 64 had a higher rate of death, 4.7 times higher than those of white ethnic minority backgrounds. So there clearly there are disparities in sort of the risk and the outcomes of COVID-19. And surprisingly, actually, is reported that in the sort of the public health reports that death rates from COVID-19 were higher in these groups, but if you look at all-cause mortality, it's the opposite feature in previous years. So something in relation to COVID-19 has caused more significant inequality. So why is there a difference? Why did we see a difference in each group of people? Unfortunately, there wasn't a national risk assessment for about 2 months since this all started. So we were seeing this in the media. We were seeing our colleagues dying from COVID-19, and there wasn't a national risk assessment for about 2 months after that. And actually, there was a statement by a United Nations working group of experts on people of African descent, and they said that even where policies may appear race neutral, the tolerance of risk without an explicit analysis based on race may facilitate discrimination and injustice. So the fact that there wasn't an investigation, people weren't asking the question why, is in fact something which indicates racial injustice and discrimination. So there've been since then have been studies to look at potential causes or risk factors for why there is a difference between ethnic minorities, and immediately people do jump to genetics, which it seems like the simple answer. They've got genes which predispose them to COVID-19 or worse outcomes from COVID-19. But in fact, if you look at the biological mechanisms, first and foremost, the problem with that theory is that you're grouping all of the Black and ethnic minorities as having same or very similar genes, and in fact they're different. And also the genes that determine immunity, etc., are also different to race. So that can't be the sole reason as to why there are differences. And people looked at comorbidities, such as diabetes and cardiovascular disease, which tends to be higher in this group of people. And then also health behaviors or education and understanding about COVID-19. And there was an interesting study about whether or not this cohort of people understood the advice that was given to them on a public health level, and whether or not information was portrayed in an understandable manner to everyone, and whether or not they had access to this information. And health-seeking behaviours, and I've talked about the loss of trust and lack of trust of individuals, and also whether or not people take Black and ethnic minority individuals seriously when they are unwell, and also things to do with socioeconomic status, and they are generally speaking are less wealthy and of poorer, live in more urban areas and overcrowded areas. So when I was looking at all other aspects, these are some of the things that came about, so genetics and a significant number of key workers who can't work from home. So there was 14% were from the Bay population, and 38% of actually key workers are Black African, which is quite a significant number of people. People initially looked into cardiometabolic factors, vitamin D levels, socioeconomic status, and where people lived. But there wasn't a clear answer. The difference couldn't be explained by either one of those things separately. And the whole issue of racism came about, especially during the Black Lives Matter protests. And interestingly so, when people started to talk about racism, this article came about ethnic minority COVID risk wasn't explained by racism, and it was said that actually it was time to stop using ethnicity when deciding who needed help, and ethnicity and structural racism were not factors when we're talking about COVID-19. And I found this article quite dangerous, and a lot of people have disregarded it as a quite dangerous article. And when we're trying to address the issues, and instead of dismissing issues, we need to address them. And the pandemic has actually highlighted flaws in grouping different people together. So people were talking about it, still not really investigating why, which is another problem in itself. And a report commissioned by Labour contradicts the government's advice on ethnicity. So Dr. Ragab Ali was the person who talked about how we should kind of not use ethnicity and structural racism in explanation. So dismissed the claims of inequalities. It was very clear that COVID-19 killed disproportionately more people from minority ethnic communities. And the COVID this report, this report came after the previous media report, said COVID has thrived on racial discrimination, and that we shouldn't dismiss it. And the problem is that we were getting high-profile people dismissing this, and even communities, certain ethnic communities, getting scapegoated during the pandemic. For example, one MP outwardly said that that he declared that actually Muslim communities, for example, weren't taking COVID seriously, and you know, it happened so that, for example, the night before Eid, 2-3 hours before Eid, lockdown was instated in certain areas, which kind of ruined the Eid for a lot of people. But it was the way it was done. Obviously, we're not going to argue with necessary measures, but it was the way it was done. So it was clear that there were differences, and in fact, workplace racism was described as a factor in BAME nurses' higher virus risk, and also doctors were talking about how they were feeling less confident, that they were about PPE provision. There was a high rate of bullying and harassment during the pandemic period, and they were feeling less confident that appropriate adjustments had been made to mitigate risk. So people were worried that if they speak out, that they would be blamed for factors out of their control. So COVID-19 has not only revealed, but exacerbated existing structural or systemic racial inequalities that are in need of urgent attention. And this was made clearer by the Black Lives Matter protests, because more people started to talk about it. More people were starting to say that there was an issue. The disproportionate impact of COVID-19 on minorities is not only directly felt in terms of health outcomes, but also is compounded by persistent unequal social impacts in housing, education, unemployment, social care, welfare, and criminal justice. And if we are serious about an NHS free of racism, we really need to come up with solutions urgently. You know, and I want to see my children not going through the same things that I've gone through, and I've seen colleagues struggle. I don't want to see that anymore, and this has been a really great event, an important event to speak out about something that people have shied away about speaking. So thank you very much.